Good afternoon. My name is Jill Manske. I'm a professor in the biology department at the University of St. Thomas. My goal today is to talk to you a little bit about pandemics, what they are, how they start, how they spread, and how infectious diseases expose the social fault lines that leave some populations at greater risk for disease than others, and highlight the racist, xenophobic lenses through which pandemics often are viewed. Before I begin, I want to acknowledge that this is not my story to tell. Instead, I'm going to try to use data, observations, and a little bit of history to try to tell this story. And I apologize in advance for any misrepresentations or mistakes that I'm likely to make. So let's begin. This is a quote that I like a lot. It's one I use in many of my classes when I'm talking about infectious disease. This is a quote by Dr. Abigail Zuger. She's a New York physician. And I want you to notice the date, 2011, way before COVID. And let's take a minute to read this, just because I think it's really important. Pandemics are never everywhere. Even in the midst of history's worst, ordinary life has always lurched on. Millions died from the flu in 1918, but many more millions were untouched. The early years of AIDS unfolded against a breathtakingly bland backdrop, the social equivalent of the crystalline blue sky on 9/11. Walk one block from hospitals on whose wards all hell is breaking loose, and you would never know there is a problem. So these are really important words, and they capture our moment, that even though this is global, it's not evenly distributed. Some people are impacted, but not everyone. It's not as if some gentle snowstorm is dropping evenly and blanketing everyone under an equal layer. It's more like a tornado, where it's devastating some people, some neighborhoods, and leaving others totally untouched. So what I'd like to do is take you through the arc of a pandemic and overlay how social circumstances drive disease and can lead to these inequitable outcomes. This is going to be a great oversimplification, but my hope is that this brief presentation will give you information and ideas to think about and reflect upon, discuss, chew on, and perhaps even act upon. So let's go here. It all starts somewhere. Pandemics arise from novel pathogen, and this is not linear or even really directional. This illustration here is greatly oversimplified, but we'll just use it as a roadmap. This is not linear, it's not fast, and it takes decades and decades of throws of the genetic dice for a new pathogen to evolve and infect a new host. And this is called spillover. And it involves this idea of an animal to human spillover of a new pathogen that can then emerge. So let's talk for a second about spillover. This slide illustrates the 4 spillover events of the 21st century. Over here, we see something we're familiar with, a pig. The pig was the spillover, or the animal that brought the pandemic H1N1, 2009 H1N1 influenza to a human population. Within this mixing pot of the pig, you've got pig viruses and human viruses and avian viruses, and they can recombine in such a way that a new virus can emerge and infect humans. And this is why the H1N1 2009 pandemic virus was sometimes referred to as the swine flu. What you see in this box here are all the coronaviruses that have spilled over into the human population in the 21st century. Some of these viruses then we've identified an intermediary animal that was the go-between between the bat and the human when it was spilled over into humans. So for SARS-CoV-2, we've identified that intermediate animal as the civet cat. MERS is another coronavirus that emerged, and the intermediate there is the dromedary camel. And then down here is what we're dealing with right now, the 2009 SARS-CoV-2, which emerged in humans, as we all know, in 2019. And I want you to pay attention to the question mark here, because we don't know what the intermediate animal is here. But some people have jumped to some conclusions. So let's talk a little bit about that. Some of you might have heard about or read about this idea of where the SARS coronavirus came from in the first place, where that spillover event occurred. And there's been a lot of talk about wet markets. So let's talk a bit about wet markets and what they are. So a wet market basically is a food market, a place where people can buy fresh meats and seafood and poultry. Perhaps some of you have been to the Pike Place Market in Seattle. You might consider that a wet market. Well, often these places, these live markets, have animals and different animals that are mixing together, and then people. So this provides an opportunity for these pathogens to mix together. If you've got different kinds of animals and humans, and we're all together, and we're in a crowded space going back and forth. So these are places where there could be an opportunity for a spillover event to occur. So when SARS-CoV-2 emerged and was identified out of Wuhan, China, there was a lot of discussion about the wet markets in China. And a lot of people calling for closing those markets because they're dangerous. And I think we need to think really broadly and carefully about this kind of rhetoric and what we're talking about, and reflect on who is impacted, who uses these markets, and what would happen if we actually did close them. Think about these markets as essential sources of food for hundreds of millions of people. Many of them are poor, many of them without refrigeration. What would the impact be on those populations if someone, we or somebody else, came in and said, just close the markets? I think that what we're doing there is often putting our values and our needs ahead of some folks who really need these kinds of resources in order to not be food insecure. So let's go back to that question mark. Remember I told you we don't know what the animal was, or even is to this point, that was the intermediate animal between the bat and human in SARS-CoV-2. And some of the rhetoric and how we discuss this really is exposing some of our racial and cultural biases. As we've learned more and gathered more evidence, it's quite likely that this virus was circulating in humans long before the Wuhan market, and that the market itself provided a super spreading event for the virus to spread because of all the crowds, but may not have been the initial source of the spillover event. But these ideas are hard to put back in the bottle once they're out. There's been a lot of xenophobia, a lot of racism around China and Asian flu and things like that. Again, not based on any evidence whatsoever. So when we think about populations and how we approach and think about who we expect to bear the burden of preventing infectious disease, I sometimes like to refer to Laurie Garrett. She's one of my favorite writers. She writes and speaks about global health all the time and is a member of the Council of Foreign Relations. This is her talking about avian influenza, H5N1 bird flu, and that when we have outbreaks of H5N1 bird flu, usually in Asia, what's expected is for poor farmers to kill all of their birds, and so protect the rest of us from this influenza. And so, as she says, it's not the rich world that's bearing the brunt of protecting itself. We're relying on poor worlds to protect us. So remember this idea of who shoulders the burden as we continue this talk. So when we think about transmission, we're all thinking about that right now. How do we interfere with transmission to try to slow down the pandemic? This is social distancing, right? This is what we're all doing right now. We're trying to stay far enough away from one another so that we don't transmit a virus. This is why I'm standing in this room by myself, is so that we don't put other people at risk. But what I'd like you to think about is this question. When is social distancing a privilege? So let's walk through a couple examples. So here's something that we all, I think, are pretty familiar with, this story of these passengers that were on the Diamond Princess cruise ship. And if you recall, these people were isolated on their ship. They could not get off the ship because we knew that there was COVID-19 on the ship. There were 24 people per 1,000 meters square on this ship. And at that density, the virus spread 4 times faster than it did in Wuhan. So just keep that in your head, 24 per 1,000 meters and 4 times faster. Well, there's other people that are stuck in other places. Right now, there are more than 25 million people living in refugee camps. And so imagine their ability to social distance. So here's just a couple examples of different refugee camps. Think about the density here, 40 people per 1,000 meters square, 204 people per 1,000 meters square. Can those people social distance? Not only that, but think about the amount of testing and other kinds of things that might be available to them. So what about closer to home? Who's at risk here? Black households, more than twice as likely to live in densely populated households. What does that mean again? What does this mean about your ability to socially distance if you're living in a crowded living situation? What about generations in the same household? Multi-generations in the same household. Again, if you're already crowded and now I've got multiple generations in my household, what does that mean? I've got different risk structures. Some people at more risk than other folks. People leaving the home to go to work. People leaving the home to go to school. People coming back. Again, all of those interactions increasing transmission and vulnerability. Many of us have already seen these kind of reports, these kind of data, and I just wanted to present it here to remind us of communities that are disproportionately impacted by COVID-19. And so what you're seeing here is from the CDC, and it's just showing cases, hospitalization, and death by race and ethnicity, and how many of our communities, compared to white communities, are so much higher in terms of cases, hospitalization, and death. And I would like to talk specifically about one particular community, the Native American community, or American Indians. In May of this year, Doctors Without Borders dispatched a group of folks to the Native American community in the southwest of the United States, in Arizona, New Mexico, to the Navajo Nation. Here is what the project coordinator said about that community's efforts in COVID. She said, "We have seen an enormous efforts by the members of these communities to contain their virus and to save lives. They provided some support, Doctors Without Borders, but until the federal government does more to address the core public health inequities, these communities will remain extremely at risk for devastation from this virus." So what I'd like to do is move on for a second and talk about a little bit about the history of some of these epidemics. What this slide is introducing to you is a story that comes out of Philadelphia in 1793. And what was happening at that time is this community was suffering from a horrible yellow fever epidemic, really bad disease. And there was a belief at the time that people from Africa or the Caribbean and all of their descendants were resistant to yellow fever. And so one of the leaders at the time, this Benjamin Rush, he recruited some other folks to help him see if they could deal with this disease. And he went to these two gentlemen who were the co-founders of the Free African American Society and recruited African Americans to basically serve as essential workers for the city. Well, they were wrong. Their Black community members were not immune, were not resistant to yellow fever. And even though they were providing essential services to the town, they died just like their white neighbors did. So let's fast forward 125 years after that situation for another vignette that illustrates some of our racist thinking that we bring to our approach to epidemics and pandemics. So this is the 1918 flu pandemic. Lots of history about this that people can dig into. But I wanted to just tell you a couple little stories. Again, for some reason, there's this racist science, and I don't even know if science is the right word, but approaches where people believe that Black people were immune to influenza and therefore would have fewer cases. And there was a very strong color line in medicine and public health. It was a very, very segregated community, segregated healthcare, segregated everything. So when influenza hit, Black people could not go to white hospitals. They could not see white doctors. They had their own hospitals, and when there was no hospital, they ended up in basements in schools. So the Black community was pretty much left on its own to fund its own hospitals, find its own nurses, and they were quickly overwhelmed. And when the flu came to Chicago, the Commissioner of Public Health, mind you, blamed Black people for bringing the disease. This is a headline from the Chicago Tribune in 1917, basically saying it was the rush of Negroes that were causing health problems. Philadelphia told Chicago that this was a problem, and Chicago basically said, well, that's not happening here. And I hope you're catching the irony of initially people thinking that Black Americans were resistant to the flu and then said, well, maybe that's not the case. Maybe it's their fault. Let's come back to 2020 for a second. Remember what Laurie Garrett said about the poor taking on the burden of protecting the wealthy? Who's essential? So if we look again at 2020, where we are now, Black workers are still more likely than other workers to be in these frontline essential jobs. Here's a quote from The Guardian in 2020. Too often Black workers have shouldered an unequal share of the burden in our struggles. And we should do everything we can to prevent this pandemic from adding to this history. Are we? Does it matter? Here's a little table, a figure from a paper that was published in September. And what these researchers did is this was out of Britain actually, and they went to a hospital and they surveyed all the workers in the hospital and looked at seroprevalence. And what that means is they were looking at who had antibodies, who had been exposed to COVID-19, whether or not they had had symptoms in the past or had been tested in the past, who had been exposed. And what did they find? Who had the highest percentage of workers that were exposed to SARS-CoV-2? Housekeeping. Housekeeping was the highest seroprevalence, even higher than folks who worked in the acute medical units, where the sickest people were. So again, let's ask ourselves, who is essential? And when does essential maybe mean invisible? Lastly, in regard to treatment and outcomes, I want to talk a little bit about this particular article. So what these authors did is they looked at the outcomes of a number of patients at a number of hospitals. Basically, the question they're asking, did Black patients die more than white patients once they got into the hospital? Super important question. And here's their conclusion. We have a lot of data to support that Black patients are disproportionately impacted by COVID. But what they found is that their Black patients and white patients, there was no difference in mortality. They died at the same rate, or were saved, recovered at the same rate. Well, that doesn't seem to make sense. We've seen all these other data that say that the outcomes are worse for Black patients. So let's unpack this a bit. A couple of things that they say. First, there's no difference for, one, those patients who were able to access hospital care. Well, that's pretty important, huh? So the only patients that they're looking at here are the patients who make it to the hospital in the first place. So think about barriers that might exist for getting hospital care, for getting health care. But even bigger than that is this. There's no difference after adjusting for socio-demographic factors and comorbidities. Well, what does that mean? What this means is this adjusting is a statistical thing we can do to isolate something from the effect you want to study. So it's a way of getting rid of all the noise. If I want to look at mortality, I can just make some other things statistically go away. So what these authors were able to do was look at mortality, but take away these things, take away the impact of socio-demographic factors, take away these comorbidities, these other diseases. But in real life, we can't do that. And even the authors say in their conclusion was that these other things may be what's impacting, what's causing these differences in outcomes. Things like, imagine this, living conditions, working circumstances, underlying health conditions. All of these things might explain the disproportionate burden of illness and death. I think that's pretty much what we've been talking about. So lastly, what I'd like to do is tell you a story well, I'm not going to tell you the story. I told you the story was not mine, and it's not. So what I have is Rabia's story. Rabia is one of our St. Thomas students. She shared a story with me about her COVID experience. I asked her if she'd be willing to share it, and she was very happy to do so in telling me that it was really important to share this story so that other people could understand and perhaps make a difference. So with that, I'll let Rabia tell her own story.
Hello everyone, my name is Rabia Sheikh. I'm a biology major. I spoke with Dr. Jill Manske over the summer and she asked me to share my coronavirus story. So in spring of, I'd say end of spring towards the finals week, my family and I got diagnosed with the coronavirus, and I remember there was around 14 days in, I remember it was getting really difficult for me to breathe because I had developed a shortness of breath. I couldn't even walk 10 steps without needing to catch my breath. So my family would help me up the steps. And I remember it was one time where I had taken a nap on the bathroom floor. I don't know how long I was out for, but by the time my family found me, we just kind of decided that it was time to seek professional, medical help. So we live in Burnsville. About 2 miles away, I'd say we have a hospital, but none of us had previously gone to that hospital before, and because we know the disparities in healthcare for Black people especially, we were kind of nervous about going to a hospital that we didn't know, and not saying that we have been treated poorly in the past by that hospital. It's just we didn't know. So my cousin actually suggested that we go to a hospital in Minneapolis. And so we waited till the morning, and we went into the hospital, and walking in, the first thing I noticed was the diverse staff. There were just a lot of people of color, and Black people in particular, that were working at that hospital. And given how we spent the night before just researching how Black people in healthcare are not being treated equally and fairly and having their pain taken seriously, it was just good walking in and seeing that there was a diverse staff. And so we got they took care of us. We got my pressure checked, my shortness of breath, they said it was fine, and all that. So we drove back from Minneapolis to Burnsville, and I remember a conversation that we were having, just kind of seeing how ridiculous it is to kind of go to all these lengths to avoid any bad outcome, and having to go all the way to Minneapolis. So because I'm a Somali woman from Kenya, so that hospital that we went to actually is situated within the Somali community. So the fact that we had to go all the way over there was just was a tough thing, because we have to make all these calculations, and it's really sad. But yeah. Thank you for listening. Have a great day. Please stay safe. Take this virus seriously. Just mask up tummies.
So in closing, let's just all remember that pandemics are not everywhere, that they're lived very differently by different people. And as we go forward and try to change our approaches and our thoughts, that we remember this and act accordingly.
Hello, my name is Kim Fredney. I'm a professor of systematic theology, and I've been invited to respond to Dr. Manske's excellent presentation about COVID-19 with a few comments that are informed by Christian theology. I'm happy to do so. I wrote my dissertation on Christian responses to the medieval plague, which got me involved also in HIV and AIDS work. Primarily, I want to convey that the same religious patterns are discernible in all three pandemics. In each case, populations feel acute levels of anxiety and fear as they grapple with mass death and with a foreboding sense of their own mortality. Religious leaders demonstrate both courage and cowardice as they attempt to lead communities of faith. And theologians pose a range of ways for pastors and priests to think about God and human suffering in the midst of widespread death and illness. Awareness of mortality is something that humans have a way of compartmentalizing. To prevent this, during the Middle Ages, the dance macabre, or dance of death, was frequently reenacted on the streets of medieval towns and villages. It was a memento mori, a reminder of death, a means of keeping death daily before the eyes of medieval Christians. Such a memento mori was hardly necessary in the 14th century when the bacillus, Yersinia pestis, or the bubonic plague, began to circulate in Europe. It is thought that about a third of the residents of Europe died in a period of only 18 months, though admittedly living through COVID, we can see how long 18 months can feel. In the Middle Ages, the cause of such widespread death was unknown. As a result, many Christians thought that God sent the plague as a punishment for sin. Priests taught their congregations that God permitted, even instructed death to enter medieval towns and villages and to decimate those populations using the arrows of famine, war, and pestilence. Priests organized processions to appease this wrathful God. They later needed to cancel these prayers when it turned out that they were super spreader events. It was controversial then, just as it has been controversial now, for archbishops and other religious authorities to cancel masses and gatherings, but these drastic measures were and are intended to protect the health and safety of the faithful. The resurgence of belief in a wrathful God recurred with AIDS and again with COVID-19. In all three cases, devotion to Mary increased within Catholic circles, since Mary promised to open her cloak and to shield from harm those who invoked her name in prayer. However, when people realized that the plague as well as HIV were taking the innocent as well as the guilty, saints as well as sinners, they could see that the illness really didn't seem to discriminate on the basis of morality. People will realize the same is true today with COVID-19. Instead of providing explanations rooted in ideas of a wrathful God who punishes sinners, Pope Francis speaks of a loving God. He hopes that in this moment the world will allow itself to be touched by other people's pain and to grow more compassionate as a result of such an encounter. He invites the faithful to dream about ways in which they can structure the world so that healthcare, education, and employment can be accessed and enjoyed by everyone. Indeed, theologians have been attentive to the social injustices that determine who is most vulnerable to infectious disease. In 2003, during the height of the HIV and AIDS pandemic, UNAIDS sponsored an international workshop for professional theologians. Participants in the workshop turned to an asset-based theological model that sought to focus on areas of strength in the relationship between Christianity and public health. Ultimately, they invited the World Health Organization to access the vast network of Christian churches that exist even in the most remote areas of the world as a means to provide immediate infrastructure for healthcare delivery. And in terms of their formal theological response, participants issued the Windhoek Report. In it, they implored pastors to emphasize images of a loving God. They invited priests to imitate Jesus, who interacted lovingly with people affected by disease, most notably lepers. They encouraged pastors to engage in the humanitarian crises unfolding in their communities. They asked leaders to utilize the rich biblical tradition of lament as a faithful expression of anger and sorrow in the midst of suffering. Finally, and as a moral imperative, they asked religious leaders to draw on principles of covenantal justice in order to examine the structural roots of oppression that worsened pandemics in communities where the poor are deprived of their rights, and to use their power and authority to advocate for meaningful change. Right now, it is good, right, and proper to mourn those who have died. It's also time to care for one another with compassionate concern, to correct structural injustices, and to celebrate the preciousness of life, recognizing that life is short, and even tragically shorter when novel bacteria, viruses, and coronaviruses attempt to thrive among us. Thank you.
Greetings, my name is Amy Finnegan. I've been invited to share a few remarks in response to Dr. Manske's presentation. My brief remarks are informed by my sociological lens and the praxis of social justice that Justice and Peace Studies offers. Dr. Manske highlighted that rates for who gets sick and who dies of COVID-19 are far worse for Indigenous people, migrants, Black people, and other targets of racism, discrimination, and marginalization. Ultimately, this is because our society is unwell, unjust, and unequal in opportunity, education, wealth, and access to care. Globally, what we've seen with COVID-19 is that resource-poor countries where patterns of extraction were set during colonialism and continue today under neoliberal development programs are most likely to be deprived of vaccines, medicine, and supplies. And the question my disciplines beg is why? What is engineering these patterns of disparity? To make sense of it, I draw on the framework of racial capitalism. Racial capitalism, today attributed to Black studies political theorist Cedric Robinson, is the idea that, quote, racialized exploitation and capital accumulation are mutually constitutive, as Whitney Laster-Purtle notes in a recent publication, surmising racial capitalism as a fundamental cause of COVID-19. Racism and capitalism are in relationship with each other, and they're constantly evolving. As geographer and abolitionist Ruth Wilson Gilmore observes, capitalism requires inequality, and racism enshrines it. This is not a new idea, nor is it unique to the U.S. society, but it is the set of ideas that are also at the root of settler colonialism and slavery in this country. Applied to COVID-19, racial capitalism helps us see that Black, Indigenous, people of color communities are more exposed and less protected from COVID-19 due to disadvantages experienced in housing, in medical care, and the economy. Chronic exposure to racism and exploitative economic conditions of capitalism have weathering effects on the body. They present as diabetes, high blood pressure, and asthma, all conditions which also put you at a higher risk of severe COVID. Racial capitalism also helps us understand how billionaires, overwhelmingly white men who have experienced tremendous advantages in housing, education, medical care, and the economy, have done so well during this time of COVID, where millions have lost work, are sick, or have passed. How specifically Mr. Jeff Bezos, the head of Amazon, a company that many of us utilize regularly, has seen his wealth increase since March 2020 by 61%, from $113 billion to $182 billion. So ultimately, racial capitalism moves us to consider how power is produced and reproduced. It helps us see how a sociologist Ruha Benjamin has noted, quote, racism produces something of value for some, unquote. And if we recognize the more profound structural determinants of racism and capitalism, the fundamental causes of disease, as public health scholars Lincoln Phelan would note, then it also shifts us to consider interventions to take on these more profound social causes. From a Justice and Peace Studies perspective, we're concerned with praxis. So how do we integrate action with our analysis? Ultimately, if we understand racial capitalism as the upstream cause of so much of the suffering experienced during the pandemic, we need to fundamentally transform relationships of power, whose impact will be felt well beyond the pandemic. we are going to need to dramatically redistribute resources. We are talking about canceling debt, expanding unemployment insurance and Medicare, providing shelter for unhoused folks, ceasing all fossil fuel infrastructure projects that seek to extract from our common natural resources, universal income programs, defunding or dismantling the police, and releasing incarcerated people. We're also going to need a dramatic reinvestment in public goods, especially in our infrastructure of care. We'll need more, not less, public resources put into our hospitals, our clinics, and other social services that serve communities most impacted by COVID. Furthermore, we're going to need to dismantle white supremacy to undo racial capitalism, work that is going to make many of us white-bodied folks very uncomfortable. This pandemic has ultimately illuminated the ugly social fractures and inequalities of our society. And it also offers us an opportunity to pause and reimagine what we want in our world, in a post-pandemic world. To that point, we'll leave you with the words of writer Arundhati Roy. Historically, pandemics have forced humans to break with the past and imagine the world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our databanks and dead ideas, our dead rivers and smoky skies behind us. Or we can walk through lightly, with little luggage, ready to imagine another world and ready to fight for it. Thanks so much for listening.
Hello, I am Fuad Naim. I teach Islam and Comparative Theology in the Theology Department. I'm very glad to be here with you today. As we live through the novel coronavirus pandemic, religious traditions can be an important source for constructively reimagining disease, suffering, and death in a culture that often resists healthy understandings of these phenomena and which views them mainly through the lens of fear. While such fear is the most natural and human response, our secular culture offers little by means of alleviating such anxieties. Other cultures and traditions had developed healthier ways to cope. Over the last 1400 years, the Islamic tradition, based on its sacred scripture, the Quran, and the teachings of the Prophet Muhammad, has offered Muslim ways of navigating disease, suffering, and death that respond to people's deepest apprehensions about them and offer attitudes by which one could integrate these as a natural, even if painful, part of ordinary life and view them as not merely harmful, but as productive of a virtuous character, enabling of spiritual growth, and ultimately a normal part of the human experience. Furthermore, as the Quran often reminds, this world where humans reside temporarily is not one's true everlasting home, but a part of a journey leading into the blessed hereafter. The Prophet Muhammad said, if you hear about an outbreak of plague in a land, do not go to it. But if plague breaks out in a place where you are staying, do not run away from it. In addition to this being sound advice to curtail the spreading of epidemics and an encouragement to build fortitude, this 7th century saying demonstrates that epidemics were a part of Muslim life from the beginning. Turning to a memorable example from 14th century Damascus, one of the most cosmopolitan cities in the Islamic world, as an epidemic was fast spreading in the city, religious scholars organized 3 days of fasting and then coming together to pray and beseech God to lift the affliction. Ibn Kathir, the famous scholar who was present, wrote that everyone in Damascus participated: Muslims, Christians, Jews, rich, poor, elderly, children, notables, all imploring God together, humbly. Even the rulers participating barefoot and in ordinary clothes. Ibn Battuta, the renowned traveler, also an eyewitness, emphasized the equality of the gathering. Here then is an example where a community faced with a terrible epidemic found ways to unite rather than divide, coming together and turning together to the one God of all people, without divisions of rank, class, age, or even religion, in the best way they knew how. Apocalypticism, conspiracy theories, xenophobic scapegoating have all unfortunately historically been responses to epidemics, especially but not only in the West. This example demonstrates that this does not have to be the only way. Coming back to the present, in an age of human arrogance, a small virus has reminded us that we are not kings, running roughshod over the natural environment and its countless denizens in our greed for material goods and our heedlessness to any higher meaning or purpose. And while the inequitous systems we have built up still disproportionately kill the already oppressed and disadvantaged, as Dr. Manske has shown, one oppressed minority has had a breath of relief from our constant aggression. Nature itself and all its non-human inhabitants. Birds can be heard singing in Wuhan again. Wild animals reclaimed the streets of cities in my native South Asia. Dolphins came back to Venice. The blue sky became visible over factory towns worldwide. In the Islamic tradition, arrogance is the original sin of Satan, the cause of his downfall, from being the most beloved of God to the most accursed. As we tread that Luciferian path in the name of so-called progress, the virus is a reminder that we are called to humility, thereby reclaiming our higher potential, as the Quran states, as custodians and protectors of all creation. Perhaps this time spent in isolation for so many over the last year, what the English Muslim theologian Abdul Hakim Murad has called a fast from our consumer capitalist culture, has brought enough of us to greater mindfulness and reflection and even humility. Unfortunately, I wouldn't count on it. Unless we actively strive to make this our permanent attitude and not just a temporary and accidental one that is gone as soon as the vaccinations start working. Until we are able to live not from greed and complacency towards our fellow human beings and all creatures great and small, we will not be able to establish the social and environmental justice that the Islamic revelation, like the other great religious and spiritual traditions of the world, calls human beings to as part of their very reason for existence. Thank you for listening.